I now request the second presenter, Aisha Salami, to present on the topic Effects of Enhanced Adherence Counseling on Viral Load Suppression among High Viral Load HIV seropositive patients in Nigerian tertiary health facility. I now request Aisha to share her screen.
Yeah, good morning. Yeah, so my presentation, I'm going to be presenting on the effect of an enhanced adherence counseling on viral load suppression among high viral load HIV seropositive patients in Nigeria tertiary health facility. So first, we want to know what is an enhanced adherence counseling. That's the EAC. So it's a continuous repetition and process that includes structured assessment of current adherence, exploration of specific barrier the patient must overcome. You know that we know that most of the time we see that our HIV patients, we just have a very low, would be unsuppressed, maybe due to some circumstances, one of which could be like maybe they are not taking their drugs, they are not adhering to their drugs. So, you know, that's why we have to do this EAC to make sure we find out what exactly the problem is, and then we try to identify the solution and then address the barrier, and also help to get an individualized adherence that will suit the issue the patient is actually having. So what are the objectives for this EAC? The objective is to assist the client, like I earlier said, is to assist this client to identify exactly what the problem is, and then to have a unique adherence corridors for them. Then who are the people that are involved in EAC? Who are the people that actually take the EAC? We have the counselors, we have the clinicians, we have the nurses, their peer group can also help. We have the nutritionists and the psychiatrists. Then those are the multidisciplinary teams that are involved in EAC. So the factors, what are the factors that affect, some of the factors that affect this EAC could be nutrition, could be a stigma or disclosure, according to WHO. So the package of this EAC to the patient is to assess the patient's specific needs, like I said, the education section and adherence counseling. So we know that if the patient, like I said earlier, if the patient is not adhering to the drugs, like the ART, obviously the viral load will increase above 1,000 copies per ml. So a persistent high viral load, it's obviously because of the non-adherence. And in order to increase the suppression, the enhanced adherence counseling is needed. According to this rate et al., it has been noted that a significant proportion of patients experience a decrease in viral load following the EAC, while others report consistently high viral load following EAC. So in 2017, there was a study that was conducted in West Africa, in Nigeria, that discovered that 86% of individuals experience viral load suppression after thorough adherence counseling. This is done by Uthman et al. And enhanced adherence counseling program objective is obviously to increase the ART adherence to a maximum treatment outcome. So the treatment adherence has evolved into critical medical, financial, psychosocial, health policy concerns today. Before initiating ART, once the patient come in at the entry point, after you know that the patient is positive, then you have to, WHO recommend a periodic education and preparation for targeted at maximum adherence. So once the patient come in and you have identified, you have done the test, you have find out that this patient is going to start treatment, you need to do a counseling. You have to educate the patient. You have to let the patient know the effects of the drugs. You have to prepare the patients and let them know what it's all about, so you'll be able to adhere. So it is critical to design the practical procedure or program that optimize patients' goal, then increase the medication adherence to ART, and guides patients through many stages of drug adherence counseling. This program would clinically enhance individual health and reduce HIV effectively on public health level. So counseling on drugs adherence is preferred to integrate into other targeted risk reduction effects. To keep a low HIV risk in the community. So the primary goal of this drug adherence counseling are as followed. The first is to assist the patient in making informed treatment decision. If you counsel the patient well, and you let them understand the effects of the drugs and all how they feel about the drugs, it will be, they'll be able to make that informed decision based on the unique circumstances. Then it also helps the patients in developing a habit of medication. Once you let them know from onset, they'll be able to, develop a habit in which they'll take their medication. Then it also helps to strengthen the patient's ability to manage and maintain the therapy. So the result of that study that was conducted in 2017, it's on the 1990 ambitious targets, found out that 787, that's about 86.5% of individual experience viral load suppression of less than 100 copies per mil over time of observation after thorough adherence. Then this study examined the effect of EAC on viral load suppression among high viral load HIV seropositive patients in Nigerian tertiary facility. So what the problem statement? So what we did was that, we tried to examine, in the hospital, we know that the lack of sustained viral load suppression after EAC counseling among some HIV patients. Then again, we noticed that inadequate integration of the EAC into existing HIV treatment and care program. Then limited availability of trained multidisciplinary teams. So when we don't have enough people to really do this EAC, it also helps to provide a hand, and in a very low resource setting. If you don't have enough, it also affects the EAC. So the optimal patients engagement in EAC and development of individualized adherence plan. Also, one of the problems is the need to improve identification and addressing of patient-specific adherence barrier during counseling section. We need to really get close. We really need to know what exactly the patient is really going through. So the challenges is we had a challenge in providing ongoing support to patients to ensure sustained adherence to antiretroviral therapy. Then we had limited data on long-term effectiveness of enhanced adherence counseling on viral suppression and treatment outcome. Then another one is the need for a systematic approach to integrating drugs adherence counseling into other targeted HIV prevention efforts. Then we need to standardization of adherence counseling protocol and training for healthcare provider. Then limited access to enhanced adherence counseling. for marginalized population include people who use drug and sex workers. So these are some of the problems. So the study, the methodology. So this study is a quantitative study that aims to determine the impact of enhanced adherence counseling on viral load in a military hospital in Abuja. So the medical records of the clients of the ART includes the EAC, included in EAC were extracted from the hospital and analyzed to determine the impact of EAC on viral load suppression of clients included in the program. So we collected all their folders in the hospital and analyzed and they were all analyzed. So the study population in this facility comprised of the HIV seropositive clients initiated on ART in the hospital, that's 063 Nigerian Air Force Hospital, Abuja, from January 2019 to December 2021. So a structured data were extracted and were designed using a Microsoft Excel to extract the client's data that are involved in EAC from the hospital. Then we and a trained abstractor was employed to conduct the data extraction and review. So, and we had to check on the completeness, the clarity and consistency of the data. So this data were exported into IMB SPSS version 28.0. So the descriptive statistics were performed presenting outcome as frequency table, percentage, pie charts, bar charts. Then an approval was gotten from the Ministry of Health, that's the ethical approval, ethical committee. So we got an approval from the ethical committee of the ministry. So this is the results. So the demographic profile shows that out of the 42 cases, 22, which is about 52.4%, were female, and with the age from the age range of 31 to 50, and a higher proportion attained secondary school, and which is about 45.2%. Then 32, which is about 76.2%, were married, and 19, which is about 45.2%, were employed in them. So then we also had clients, about 33 clients with viral load results. That's 14 of them, which is about 42.4, had very low viral load, which is very mere. That's about less than 50 copies per mil, and 10, which is about 30.3%, had low level viremia, which is about which is between 50 to 1,000 copies of viral load copies per mil. But 9, which is about 27.3%, still had high viremia, which is more than 1,000 copies per mil. So this is the table. So we see that the age, the gender, the female were really more than the male. Then we have the age categories 10 to 30, 31 to 50, which is more, which is the 52%. So these are the ones, the highest, this is the highest, we categorize them into primary, secondary, and tertiary education. So this is then the marital status, if they are single, married, or separated. Then the occupation, the students, the unemployed, the employed, and the ones that are doing business, the businessmen. So the people, so we now So we now again categorize them into viral load, very low viremia, which is 50%, less than 50 copies, then low viremia, 50 to 100 copies, and then high viremia. So this, then we had, we now again, what we did again was that we enrolled them. So we noticed that the people that are that have been on ART for 6 to 10 years, that's about 67.6%. And then the ones that are more than 10 years is 42.9%. And 9.5 have been on ART for like 1 to 5 years. So you can see the percentage and the duration in which they've been on ART. So the high proportion of these respondents, which is 76.2%, were on first-line ART regimens, while 23.8% were on the second line regimens. Also, a significant proportion, which is 97.6% of the clients enrolled in EAC, were at the stage 1 of the WHO stage 1 HIV infection. And only one, which is 2.4%, was on the stage 4 WHO HIV infection. So 50% of the participants said that their reason for testing viral load was due to viral the viral PLIPs, which is 28.6% due to unsuppressed viral load, and 21.4% were tested to monitor for viral load. So what this means that, when they come in, they had this viral load twice in a year, 6 months and 1 year. So when we check after the one, when the viral load is actually very low, then you do the EAC for like 3 months. So after 3 months, and you notice that the viral load is low, then you have to do another. You do the EAC. After the EAC, then you do another viral load for them. So if the EAC is very low, then you have to change the medication to a second line. The discussion is that 47.6% of these HIV patients enrolled in EAC, they use the ART consistently. That's for 6 to 10 years. Then this indicates that most of them have been on ART for a long time. Then this was similar to the finding by Mlay and A, that's 2019, and Wakoko in 2020. However, the finding of this study were contrary to a study by Raja et al. In 2016, which discovered a low rate among those who have been on ART for a long time. So for those who have been on ART for a long time, you notice that they are not very consistent. So some study also suggests that earlier initiation to ART may also improve retention rates in care and medication adherence and promote the more rapid achievement of viral load suppression. Based on the finding of this study, a high proportion of people living with HIV enrolled in EAC, that's 76.2%, was on the first line of ART regimen, while 23.8% were on the second line. So the study also revealed that most HIV patients who joined EAC were on WHO stage 1 HIV infection, and a large percentage of these patients were on the first of the ART regiment, first line of the ART regiment. The finding of this study were contrary to a study carried out by Wakoko, who discovered that majority of the participants were on WHO clinical stage 2 and 3, and second-line ART regimens. So it is recommended that the first line of treatment be given to those who were in the first WHO clinical stage of the disease. So conclusion. So according to the finding of this study, majority of the participants enrolled in EAC were who have had the ART for that long, as long as 6 to 10 years, were on the first line of the ART regimen and WHO stage 1 infection level. Also, the finding of this study shows that majority of HIV clients have low viral load after 3 months of EAC. This shows that EAC were effective in suppressing the viral load of the HIV patient. Furthermore, pill burdens was found in a majority reason, to be a major reason for inclusion of the EAC. Likewise, the viral plebs for viral load testing. Overall, this study shows that EAC has a positive impact on viral load suppression among people living with HIV. Given this result, it is recommended to continue promoting and expanding the EAC program to reach more HIV patients and improve on health outcome. It may also be worthy exploring strategies to address the pill burden, such as the use of combination of ART drugs to improve adherence and reduce the burden of taking multiple medication. Furthermore, more research is needed to carefully understand the factor contributing to viral plebs and identify ways to mitigate this issue. So these are the references. Thank you.
Thank you, Aisha. Thank you for your wonderful presentation. Now we move on to the Q&A.
Okay, thank you so much, Aisha, for that. I had put a question in the box, but I just want to ask, from my knowledge in Nigeria, the HIV system in Nigeria have very good adherence counseling system. And it's actually one of the ones that a lot of people refer to in terms of when you want to kind of institute adherence counseling in your disease program. Please, can you tell me, like expatiate more for me on this, the reason for this adherence counseling? Is it that it's no more as strong as it used to be at the beginning, or healthcare workers' knowledge needs to be improved on it? Thank you.
Okay. Can I answer the question?
Yes, you can answer. Yes, you can answer.
Yeah, thank you very much for the question, Obioma. So you know that a lot of HIV healthcare workers, some of them we have, like for the facility that I use, it's a military environment, and so there's this kind of attrition. So people that have been trained might leave for another facility, and so maybe a facility that doesn't even have to do with the HIV program. So training and retraining is one of the things that we need to be able to help these patients in, because a lot of them would not, if the counseling is not done properly, it's obviously going to affect the patients. And so you see that most patients, they fail in this EAC. I hope that answered the question.
Thank you, Aisha. Thank you. In chat box, we have a question for you. I'll read it out for you. Did you measure adherence in the study? If you did, how did you do it? It was from Mr. Joseph.
Come again.
Yeah, I'll read it again. Did you measure adherence in the study? If you did,
did you share adherence?
Yeah. Did you measure adherence in the study? And if you did it, how did you do it?
I didn't get that question. Did you mention adherence in the study?
Yeah.
And if you did,
how did you do it?
Yeah, so our the EAC was, what we did was we got some you know, the EAC has actually been done. So what we did was to get their folders and try to collate all the people that have done adherence in that facility. Then we compare what's the results, we check the sex, the age and everything, and check the results, check their results. People that have done adherence, they have done this adherence. What is the result after the adherence? Was the adherence helpful or not?
Yeah, what I was good. Thank you for that presentation. What I was trying to ask is that she has been talking about adherence. I want to ask, did she measure adherence in the study? And if she did, how did?
I can't hear you, please.
Are you hearing me now?
Yeah, I can hear you now.
Yeah, did you measure adherence in the study?
Did I measure it or mention? Did I measure?
Did you measure ASURE? Measure adherence in the study, and if you did, how did you do the measurement?
No, I did not.
Measure adherence. Okay, it's okay. I heard you talking about adherence. Okay, thank you.
Thank you, Aisha, for your wonderful presentation and for answering the questions.